Surfing the Healthcare Tsunami, Bring Your Best Board. This is one of a series of webinars where we'll really be tackling the issues of the boardroom. And what I'd like to do is just remind everyone that you can go to safetyleaders.org, www.safetyleaders.org, to be able to download the slides. Kyle, please advance. I don't appear to have control over the slides. Next slide, please. Slide 3. And we'd like to make sure that if you don't have good audio control, we'd like to make sure you turn up the volume on your computer so that you can get the best audio. But if you fail doing that, you can request a phone line at the bottom left-hand corner of your screen. And we are on slide 3. I'd like to remind you to go to www.safetyleaders.org, and in the upper right panel of the website on the landing page, you can click on this webinar, and it will take you to the page where you can download the slides. And then within 2 business days, we'll have a transcript that's word searchable, as well as audio recording and the slides, so that you can watch it asynchronously. I'm on slide 6. If you wish to follow us on Twitter and Facebook, if you go to slide 6, you can find out how, and you can use the hashtag #SafetyLeaders. Our mission on slide 7 is to accelerate performance solutions that save lives, save money, and build value in the communities we serve. We know that ground zero in the war on healthcare harm is the boardroom. And my next slide, slide 8, I have the pictures of the panel, all but Dr. Parda, who has also joined us. And we have a terrific set of panelists that have a rich experience, either as trustees, clinical and non-clinical, chairman of the quality committee boards of major hospitals, as well as quality leaders and patient activists and patient advocates. You can see our disclosure statement on slide 9, which I will not read for you, but you may review it. And we will not be addressing any pharmaceutical product or product during this webinar. I'd like to do what we usually do, is just turn over the mic to a wonderful dear friend, wonderful patient advocate and champion, who is both an executive in search for board members, as well as CEOs and C-suite leaders and patient safety officers. But what's more is that he is an absolutely dedicated patient champion, very articulate, and a wonderful contributor to the movement. And we'd like to have Dan really open us with 30 seconds of just to focus our thoughts. And then when we are in our panel, he will also join our panel, and we'll also ask Dan to prioritize having the last word when we close. Dan, would you launch us?
I would, Chuck. Thank you, and I appreciate being involved, and welcome everybody as well. Chuck mentioned I'm a search consultant, also because of that experience in our family. I've become a very passionate and strong patient safety advocate. Just a few thoughts on what matters to patients, and I strongly think should be important to those who serve on boards and have governance responsibilities. Hospital needs to view patients and families as partners with respect, not as uninformed interlopers, and they want to be listened to. Patients want to be fixed, relieved from pain, return to good health, assisted in delivering healthy babies. To quote my good friend John Toussaint, patient and family-centered culture and a commitment that starts at the top with board and the CEO, as well as frontline staff. Also, the hospital needs to take responsibility when errors happen, with open disclosure, apologies, transparency, integrity, honesty, and plans for constructive change. We need a culture that needs to be endorsed from the top, that invites and supports bedside patient advocates 24/7. And we need a culture that invites speaking up and asking questions. That's all for now. Chuck, thank you.
Thanks very much, Dan. Really appreciate it. And now it's really a distinct honor to present with Rosemary Gibson issues regarding testing. And we do so to provide some tangible areas that we can target when we're in the boardroom. Not only do we want to cover the lofty principles and the concepts and the issues around trustees who really are most responsible for the safety net that must protect our caregivers and our patients, that is composed of the threads of leadership practices and technologies, but we really need to talk about key issues that are timely that we could bring up today. And there is no more important topic than really focusing on what we do in testing. It's really kind of an invisible taxation on our healthcare system, and it represents just staggering opportunities for improvement. So Rosemary will lead off and talk about testing, and I will then follow up with a program that we've launched called the 5 Rights for Imaging. Rosemary is a nationally recognized leader in patient safety. She's the principal author of The Treatment Trap, a book that highlights the overuse of unnecessary medical care. She's the section editor of the Archives of Internal Medicine series, Less is More, which publishes narratives of patient experience. And I think what's more is that she has a wonderful strategic view of healthcare and what we need to do, but a very thoughtful and incisive mind that really focuses on tactical issues that are really practical. So Rosemary, please lead us off in this area of testing, and I'll follow with the 5 Rights of Imaging, and then we'll go to our next speaker.
Thank you, Chuck. Good morning and good afternoon to all of you. I'm going to start off this very brief overview with a patient narrative. It's a real case of a patient who came to a hospital emergency department in New Jersey. And the reason I'm starting with a patient case is because the ultimate purpose of why we're all here and doing what we do is because it's about patient care. And secondly, as Chuck mentioned, it's a nice lead-in to what he'll be talking about with the 5 Rights of Imaging. And also we'll be hearing more from one of the panelists about what it's like to get a call from the New York Times asking questions about why do you have a high rate of double chest CT scans. Next slide, please. So this is a case of a 27-year-old woman who presented at a New Jersey hospital emergency department complaining of abdominal pain, and she asked for a CT scan. She was seen by a very seasoned internist who examined her, and he learned from the patient that she had had multiple bouts of abdominal pain that had not been resolved. And it turns out she had been to the same ED on multiple prior occasions. Next slide, please. The internist reviewed her medical record, and he found that the patient had had 9 CT scans over the course of more than a year, and at that same hospital, and none of the scans had revealed an explanation for the patient's pain. And so, of course, she kept coming back, and that was her primary concern. The internist explained to her the risks of another CT scan. Being a young woman of childbearing age, he said to her that this, could be damaging to her reproductive organs. But then he did something that no other physician had done for her, and he correctly diagnosed her abdominal pain as a cause of lead poisoning, and the patient was appropriately treated. The internist is director of the internal medicine residency program at his hospital, and he asked a resident and nurse practitioner to write up this case. It certainly brings up a number of different issues, certainly diagnostic quality and CT scan overuse, which were prominent aspects in this case. But for today's call, we're going to focus on the diagnostic imaging part. And the question for all of us, and I hope this case can weave through some of our dialogue for the rest of our hour and a half together, it seems there can be some things that we can learn from this case, both for patients, for doctors, and for board members. Next slide. So what might have been going through the patient's mind? She had gone back and forth to this emergency department on many occasions, and she may have been led to believe, because she had been given CT scans upon each of her presentations at the ED, she perhaps came to believe that a repeat CT scan was good medical care, which led her to request another one. I refer to this as patients having our minds being marinated to believe that more care is better care, particularly in the absence of knowing anything to the contrary. the absence of knowing the potential risks of cumulative radiation doses. Next slide. And that's why I wrote the book, The Treatment Trap, for the public to understand what are some of the risks of too much medical care. Next slide, please. So how would the patient be informed of the risk of cumulative radiation from abdominal CT scans? The average person probably doesn't know. They may have some awareness of it because there have been some reports in the media, Associated Press articles that have circulated around the country, in particular when President Obama had one of his coronary calcium CT scans. There was a piece written that got around to the many newspapers, Boston Globe among others, about whether that test was appropriate and the radiation exposure that he received. So how can patients be informed, and should patients be informed when they ask about a CT scan? And if so, how do we talk about these risks to patients? On the one hand, we don't want to frighten them. On the other hand, we want to enlighten them to make sure that they are aware of the benefits and the risks and helping them make trade-offs. One of the challenges to having an informed patient is that surveys and the literature shows that here in 2 studies noted on this slide, in a convenient sample of doctors, few had any knowledge about the level of radiation that their patients were exposed to during radiological investigations. It was an older study from the BMJ. And more recently, in a meta-analysis of 14 articles, showed moderate to low knowledge of radiation exposure. So there's a challenge about our awareness of radiation exposure, which makes it more challenging for patients to be aware of the risks in relation to the benefit. So let's talk about the hospital. What would have happened in your hospital? Do ER physicians have access to information on prior CT scans performed at that hospital? What improvements could your hospital make to avoid this situation? What are some of the barriers to making those changes? Next slide. And for board members, is overuse of unnecessary tests and surgeries a topic of board discussion as part of quality and patient safety? Are there unique challenges to discussing overuse as a safety issue? Do your board members know what overuse is? According to the Institute of Medicine, it's when the potential for harm of a healthcare service exceeds the possible benefit. And that certainly would have been the case of this young woman. Next slide, please. So for board members, what questions would you ask or would you have about how to prevent a similar occurrence in your institution? Does the hospital regularly review CT scan use to identify outliers in terms of possible overuse? Is that the kind of question you might ask? Or what are the reasons that outlier cases occur and what can be done to prevent them? And again, what are some of the barriers? Next slide, please. Is there an opportunity to initiate a conversation with boards about overuse? In December 2011, the Joint Commission proposed a new national patient safety goal on the topic of overuse. It proposed that beginning in 2003, accredited hospitals would have to select a treatment or a procedure or test where there's evidence of overuse. They suggested some areas of overuse that included CT scans, along with, you'll see there, cardiac stents, early induction of labor. Next slide. And according to the proposed patient safety goal, the hospital would have to evaluate whether overuse is occurring, how it can be addressed, and beginning in 2014, actually begin to reduce it. And here it's an example of offering the opportunity for board members to understand this dimension of quality and safety, which hasn't received as much attention as other domains of quality. Next slide, please. You'll be hearing later about the New York Times calling on a hospital and asking about a hospital's higher rate of double chest CT scans. That came from a National Quality Forum endorsed diagnostic imaging measure. And next slide, this data is reported on Hospital Compare, so you can go online. In fact, your board members might find this of interest. Type in your zip code, and you can search whether your hospital is at high rate of double chest CT scans. Next slide. and there's more information about how hospitals fared. Most hospitals were doing just fine. There was a small percentage of hospitals where there were red flags for high rates of chest CT scans. Next slide, please. But even to make it easier, New York Times on June 17, 2011 published this interactive map where lay people and professionals and CEOs alike could check whether their hospital was an outlier. So I'll stop there just to jumpstart the conversation about this important question for patients, for hospitals, and for board members. Thank you.
Great. Thank you very much, Rosemary. And Kyle, if you could hand me the ball. Now, what we'll do is really kind of build a little bit more of the story on imaging. However, what I want to do is really set up the context of a series of our webinars where we'll be really focusing on the boardroom and use imaging as but one example. And so basically, you know, we're in a real crisis, and we use the concept of the CMO, claim, evidence, message, offering format to describe a value proposition. When we're talking to the boardrooms, we're talking about the no outcome, no income tsunami that is coming their way, and that some will be surfers and leverage the power of the wave, some will be swimmers and get thrown in the drink and watch what happens, and the sinkers will perish and wonder what happened. So you want to be a surfer that makes things happen. We have a $100 trillion unfunded liability. Congress is likely going to push things until after an election. We know that we are facing cuts. And in blue, you see we will move from a provider-centered, volume-driven paradigm or model to a patient-centered, value-driven paradigm where instead of looking for more and more volume of patients and studies and a la carte revenue, we're going to start to be paid for taking care of populations and individual patient care. Total shift in paradigm. So at TMIT, one of our programs is this 5 rights of imaging, as well as speaker link, which Frank will describe a little bit later, of linking patients and families with those in the boardroom and the quality and performance improvement teams to really get patients there. And we also have a Discovery Channel movie, which will be premiering shortly, which really will address this issue of the 5 rights of imaging as one of the examples. Slide 34 addresses the article where we, our second article regarding this no outcome, no income tsunami, where we use this metaphor. The first was in 2002. We have another one that will be coming out that will address and be a companion with the movie, the Discovery Channel movie, that will be premiered in Washington on the 26th of April and then 27th. We're going to showcase this issue of imaging as one of the examples of addressing the board. When we say that we're going to have to surf this tsunami, we say we need to bring our best board, and that is an informed and engaged board, likely a different board than we have in the future. We'll have a summit on April 27th at the National Press Club where we'll be addressing a number of the green light projects, and that will be streamed live from the National Press Club globally over the internet, and we'll have a number of folks involved. And you see on the next slide Dr. Howard Koh, the Assistant Secretary of Health, David Hunt, the medical officer and lead medical officer for the Office of the National Coordinator of HIT, Sully Sullenberger, John Nance, David Bates, Leah Binder at Leapfrog, and then leaders from CMS and ARC and other agencies. And we'll be addressing some of the findings that we've had, focusing on impact calculators that allow us to really focus on proper testing, overuse, underuse, and misuse, because there is an underuse issue when we have the fear of radiation safety. We'll have a special issue of the Journal of Patient Safety that focuses on imaging, high-value performance of imaging, where we'll be releasing some new real blockbuster data regarding the use of imaging, which I'll get to in a moment. I just wanted to remind everyone that the 2010 Safe Practices for Better Healthcare, distributed by the National Quality Forum, actually describes what board members really need to focus on. Safe Practice 1 is the culture of safety, the leadership structures and systems which must be in place. And specifically for board members on slide 41, governance boards and senior administrative leaders leaders should regularly and thoroughly be briefed on the identification and mitigation of risks and hazards. We will this year likely do between 80 million and 100 million CT scans. The overuse is expected to be about 30%, which means by those that are really forecasting the potential risk to patients, the carcinogenesis of those on that end of the continuum that believe the numbers that have been calculated based on Hiroshima and Nagasaki are that we'll have over 29,000 cancers from the overuse. Governance boards and senior management briefings must be undertaken as the safe practice, and there must be direct accountability of governance boards. These are national standards that now may be used by payers to tie accountability to the boards. Safe Practice 3, and I'm on slide 43, now 44, addresses that risks and hazards should be identified on an ongoing basis and that there need to be independent, retrospective, and real-time, near real-time perspective reviews. And these analyses need to be focused on the systems and using data. So I think that this new income tsunami that will be tying payment to quality will be leveraging a lot of the national measure standards and practices to tie payment to performance. So our Greenlight program, where we have a number of collaborative hospitals, which you see on slide 45, are addressing this issue of CT and imaging, high-performance imaging, starting with CT. Slide 46 was a release from Consumer Reports. Do you need the CT scan? And so what we've done is we've been looking at radiation safety, overuse, underuse, misuse. What are the 5 rights for imaging? What are the right studies? What are the right order issues? What are the right way that the studies be undertaken? What are the right report principles and practices? And then what are the right actions that they should drive? The New York Times has had a series of articles and will continue with an author, Walt Bogdanich, that has addressed the overdose issues of CT that are more related to the practices, the technologies, and leadership. We'll just, because we'd like to get to our panel, we'd like to just remind you of the 4 A's that are in the safe practices. We've stratified awareness, accountability, ability and action of risk against leadership, practices, and technologies. These are the threads of the safety net that really protect us and protect us as caregivers and protect our patients. Now, if we were to look at the hospital, many of the facilities that have had the accidents of one type or another, perhaps it's overdosing a child and using adult protocols and not using the image gently approach to reducing the dose and the amount of radiation that's delivered to do CT scans on children. Or perhaps it's where overdoses have occurred because of protocols used on the machines, or perhaps it is the lack of sticking to the protocols. In those instances, this is what we see, is that leadership is unaware, not accountable, does not really know what they need to be focused on, and really does not have direct actions on these risks. So what you see as the pattern on slide 49 is not uncommon, and we've seen that in our research with hospitals and healthcare systems where they've had these such accidents or overdose. We had a surprised group. We have groups that are pioneering radiation safety when they went back to their technologists. The picture of slide 50 was the leadership was unaware. Folks had let the protocols slip and were not administrating the use of imaging in the way that they know that they should in their protocols. This slide depicts what experts who thought they were doing a good job realized when they went back after the rash of accidents that occurred in imaging and the overuse, underuse, misuse of CT. And slide 51 are some of our high performers in our Greenlight program who have been vigilant in leadership practices and technologies. So really tie that back to the safe practices. I'll just conclude by addressing this issue of the 5 Rights program. We're undertaking a deep dive with many, many papers. We've got 10 on the launch pad with probably another 10 to follow, addressing the right study, which is the choice of the right study, the first question of our, and we've developed a checklist for consumers and for doctors. Is that study indicated? 1 in 5 are done because we can't find the prior information. That's 1 in 5. That's 20%. Right order, as many as 40 to 60% of CTs that are ordered or ordered improperly. The request is not articulated with what the doctor really needs, or there's incomplete information for the radiologist. The right way at the bottom, at the 6 o'clock position, is using the right protocols, the right procedures, as well as the right low-dose equipment. The right report is making sure the report gets to the right individuals, and did it answer the questions that for which the CT or the image or the test was ordered, and then finally the right action. Studies have shown that those that are taking care of active medical problems are not receiving these tests, and this is why we end up with really high volume. And the fallback is always, oh, well, we're practicing, it's those doggone malpractice attorneys, we're practicing defensive medicine. I will submit to you with the data that you'll see through this year and the next year that we'll be publishing, that it's more defense of their volume-driven practice than it is defense of the risk of malpractice, meaning that if you have to pay a staff person and your practice has 3 or 4 doctors an hour or 2 hours to go get a prior CT scanner report, you just can't do that and keep your volume of 40 or 50 patients a day, and therefore you justify ordering a new test. And it's many times more the defense of a volume-driven, provider-centered paradigm than it is the other. The final note is that there is significant underuse, and it's critical that we deal with the radiation scare and the overuse scare to prevent things like patients that we know in our teaching institutions who have declined CT scans preoperatively for major abdominal surgery because of radiation risk. And as Rosemary said, the doctors could not explain adequately, or maybe the fear was just too great to convince a patient a life-saving CT scan that could really guide the surgeon's hands was not undertaken, putting both the patient and the caregiver at risk. And again, here's underuse because the fear of radiation. So there's as big a challenge before us with underuse as there is overuse or misuse. So what I'd like to do now is just introduce Dr. Bill Scharf, who's going to now really guide us to our discussion regarding dealing with boards. Rosemary and I have kind of teed up the issue of testing, and we've given you some meat to kind of think about. But what we'd like to do now is take a real live leader at one of our great organizations who successfully discussed this issue of imaging, and I really look forward to the lessons that Bill can share with us in his formal presentation, but also in answering questions that we're going to tee up for our panel. Bill is a longtime friend, a terrific leader at OSF Healthcare Systems. He is a general surgeon that operated in their system and now has a wonderful title of physician change agent in the Division of Strategic Effectiveness at OSF. He's medical degree from the University of Illinois and has been a longtime champion of patient safety and quality, and he always says that he had a hard time filling John Whittington's shoes, but from what I've seen, he's doing a heck of a job creating new ones. So, Bill, would you please take us away and really explain to us and tell us the story of what it's been like to kind of take this imaging issue to the boardroom and what you faced and what you learned?
Our journey began last summer when one of our marketing directors in the Upper Peninsula of Michigan received a call from the New York Times. And the question that the New York Times reporter wanted was, why was there a high rate of double CT scans at that organization? Next slide. And so the data set by which the reporter was calling about was that from a hospital compare, which Rosemary had discussed earlier. And this is something that if you haven't seen this for your own hospital yet, you really should be familiar with this. Next slide. And so a couple of days after this inquiry came, the New York Times had published this article. And one of the things that we do in our organization is what we call signal detection theory. And that is that if there is a light that comes crashing down in your room, in a room full of people, the first thing that you're going to do is say, are you okay? But the next thing that you're going to do is you're going to start looking at the other lights to see if they're at risk of crashing down as well. And since we're part of an integrated healthcare system, we started looking around to see if any of our other hospitals had some of the similar problems. And if you go to the next slide, what we found was that indeed there were 2 other of our OSF facilities that had higher rates double CT scans than we would have otherwise expected. And so here's the take-home message, and that is that no one can hide from the bright lights of transparency. And if you think that you can, you're really sorely mistaken. And that the bright lights of transparency are going to make some folks look favorable, but others are going to look rather unflattering. So the next slide. One of the things that was in this New York Times was this quote. I won't read it, but basically what this says is that CMS and other organizations are going to look for those areas where there's low quality and high cost. Now, from the standpoint of signal detection theory, we looked not only at whether we were having problems with a high rate of double CT scans, but the generic issue of radiation exposure. And what we presented was, or formulated in our mind, or articulated to the board, as if you can see the next slide, and we asked the question was, is radiation exposure the new asbestos? So you can imagine just standing there in front of the board, we had their attention from the media exposure that had occurred from a risk standpoint, and now it was time to communicate to the board in terms of what the things that they needed to know. Now, just in general, and speaking in front of any board, I won't go through some of the more common topics that folks typically talk about, but just three things that you may not have thought of in the past. First of all, whenever we go in front of the board, it can be a rather intimidating experience. And what we have is so much different than the folks who present the building projects. They have it easy because the new projects generate lots of excitement and interest. But for those of us who are involved in safety, we're sometimes confronted with this need to tell the board the inconvenient truth of what they need to know. And as a messenger, we can bear some really bad news, and that can be an experience, can be a scary experience. But one of the first thing that I like to say, and that is that what you may not know is that board members often have the same fears too. They're entrusted with this very humbling experience that they're responsible for both the fiduciary obligations of the hospital as well as safety and quality. And it's that latter obligation, safety and quality, that scares the daylights out of them. It scares them because it affects people's lives. Sometimes it's their friends and neighbors. And besides, any problem you can fix with money really isn't a problem. And so it's the other aspect is that just healthcare in general is so complex that sometimes people don't even know where to begin. And for our non-clinical board members, they can be really overwhelmed. They look to us. They want explanations. They're looking for causes. They're looking for solutions. And so this is our opportunity to help provide guidance. So what can one do in terms of being effective in terms of making presentations to the board? One suggestion, I think, and that is to get to know your board members. Make sure to take time between breaks, introduce yourself to them, invite them out on tracers. Get them to go to your walk rounds. Find out who they are and what they think, because you want to know them, and chances are they probably have some very touching story about how they or their family members interface with healthcare on a very personal level. And some of these are wonderful learning opportunities. So why is all this important? Well, because when it's time to have a crucial conversation about a hospital event, you want to rely on somebody whose trust you have created. And so the personal and professional relationships that you've created can be very helpful when times get tough. The second concept that I'd like to bring about, and that is that boards are very diverse. I know this seems like the master of the obvious, but it's a common problem and one that I face from a number of different folks who raise this issue. And the thing is that clinicians can't have any idea how non-clinicians can make decisions that affect their clinical work. And sometimes clinicians, the non-clinicians, the board members, are uncomfortable about making decisions that affect clinicians. So the one thing that we have to realize is that board members come from a variety of different backgrounds. On our own board, we have religious members and members of the lay community, clinical members, non-clinical members. So when you go to you're speaking in front of your board, you got to realize that you're speaking to a whole range of folks. It could be business executives, accountants, lawyers, other influential members of the community, and they come from a lot of different backgrounds. And the boards are diverse for a reason. Increased diversity generally helps organizations make better decisions. And so why is that important? And that is because when it came time for us to speak in front of the board, we had to start at a very basic level and work up. If I were to assume that they were at a clinical level about x-rays, I was going to lose them. And that was going to mean that I was going to be unsuccessful in communicating the gravity of the situation or any other potential suggestions or recommendations that we were to make. So when it came time to talk about double CT scans, we had to first start out with a basic foundation of what radiation is. We had to start with a discussion about terrestrial and cosmic radiation, how that compares to average radiation of different medical studies. And then from then, now I could start to launch into discussion about double CT scans, of which most of the board members had no idea what a double CT scan was. But there's a second reason. I think this is more important, is that some of the non-clinical board members might be afraid of conflict. And so our job when speaking to them is to help them to be decisive but yet not autocratic. Because after all, their job, as spelled out in the conditions of participation, is to ensure that the medical staff is accountable for the quality of care that is provided. So the third point that I'd like to make before finishing up, and that is that whenever you speak in front of the board, you're a teacher. Oddly enough, some boards some boards don't know the requirements of the conditions of participation, and they may not know that a board has to ensure that each hospital's medical staff is accountable for that quality of care. And you may need to teach the board what their job is, and that may put you in a rather uncomfortable situation. But being a teacher also means that you need to teach principles of safety and quality. A board needs to understand that safety is a system property. They got to understand the difference between active and latent error. They should know differences between linear and dynamic models of safety, of signal detection theory, and engineering resilience. So why is that all important, that they have a more sophisticated understanding? Is because when it comes time for them to make decisions, they're going to be aligning their mission, vision, and values. But if they don't have a sound footing of theoretical safety principles, it's very possible that the decisions that they make could be ineffective or sometimes even counterproductive. So just imagine if you're standing in front of a board and you want to have a discussion about wrong site surgery or wrong instrument count. On face value, a board member who's sitting back in the seats may become unraveled because they're trying to understand just how on earth can you leave an instrument behind and then come and say that the count was correct. Or how can an entire team perform an operation on the wrong side? But that decision is going to be a lot easier if you've got a solid footing in error as a system property. So one of the questions I would say is that people would ask is how do you introduce safety principles to the board? And the thing that I find is very valuable is to segue from a safety concept. Segue from your opening story, the opening story that really touches and connects people to the issues of safety, and then tie that into a statistical principle or a theoretical concept. And then as you're doing this, it's sometimes great to see the light bulbs start going off. And pretty soon, when you start hearing that their discussion becomes peppered with this new vocabulary of safety principles and quality, then you know that you're there and you're ready to take on the day. So these are just a couple of the observations I made. I'm certainly interested in what others hear as well. So Chuck?
Bill, fabulous! Really, really a great start for us. And so we've already heard from Dan Ford and Rosemary Gibson and Bill Scharf. It's a real honor to introduce a wonderful trustee, Sharon Rosemark. Sharon has had more than 30 years of experience in financial services, insurance, and e-commerce areas. She is a leader of Zeus Global Ventures. Most importantly, she is a board member, a business leader who is a board member of Sinai Hospital Health System in the Chicago area. And we have had the pleasure of having her spend real significant time with us on the development of our board training program and the movie that is Surfing the Healthcare Tsunami, Bring Your Best Board. Also, Ellen Bristois, and Ellen is a nurse by training, a longstanding trustee in the Cleveland Clinic system, and both Ellen and Sharon have representation on the quality committees of their organizations, with Sharon being the chair. So what I'd like to do is start off with the two of them, and then I'll ask our other other panelists to jump in on our next slide. But before I move to that, Tom Knight is a longtime colleague and a terrific patient safety champion who has led patient safety and quality at Texas Methodist Hospital in Houston, and now is relocating to Austin, Texas, where he will be the lead in that capacity for the St. David's Healthcare System in Texas. And Dr. David Parda, who's the chairman of radiation oncology at West Penn Allegheny System, and a board member who is a physician board member. So we have a business person who is a board member, a nurse, a physician, and then two quality leaders to all respond to some of the questions that I'm going to pose. I'm going to go through the next slide on slide 63. I'd like to get Sharon first and then Ellen's reaction to these four topics on slide 63, and then we'll open it up to Tom and to Dave and to Bill and Rosemary. But this issue of quality and safety officers engaging boards. Sharon first and then Ellen, could you really address these topics and pick one, and then we'll kind of go back and forth. But typically the board is CEO land. We have great sensitivity of our CEOs to not embarrass them, and they tend to really want to make sure that we aren't introducing something that could be a real problem for them and the organization with the board. Examples of engagement of boards by the quality team. Sharon, I know you are the chair at Sinai, and quality committee opportunities. Both of you serve in those capacities. And then finally on stories. So Sharon, CEO land and engaging the boards. Give us your view as a business leader who is now a trustee and chairman of the quality committee.
Well, thanks, Chuck. I would say that, first of all, it's important to not look at it as CEO land. I think it's important for the board members to understand their role and while they're there and why they are there. In particular, it's important to make sure that, first of all, there is an established quality committee with board members who are engaged. Secondly, I would say that it's important to make sure that quality is on the board's agenda on a regular basis. And it depends on how frequently your board meets, but certainly for the executive committee and then an update for the full board. And then the third piece I would say that's important is for board members to attend and participate in quality training events and programs both internally and externally.
And Sharon, any advice to those? We have many quality and safety leaders in our communities of reaching out to the board, knowing it's, one of the perspectives you shared with us is the board really does want to hear from the quality and safety folks. Is that a fair statement? And I think most would be surprised to know that.
Yes, I would say that is a very fair statement. In particular, what are the issues that they need to know about that they wouldn't know to ask? So don't be afraid to share those key issues with the board and engage them in full, transparent conversation.
And Ellen, you come to this perspective having worn multiple hats as an educator, as a nurse, and a long-standing trustee. And you and I have often laughed about the fact that you were one of the first female board members and probably one of the first nursing board members, and in an environment that was fairly hostile to both. And you have really been able to ride the wave of being a great contributor on the board. What's your perspective and advice to those of us that really want to get our message to the board, but how do we do it, and what's the best way to really engage? Are there successful examples you'd like to share, and then your perspective as a clinical board member?
Well, to address your first point, I echo the previous speaker in terms of continuing education. And I'd like to bounce back to your first item. Is there a way to bring more to the board without offending perhaps sensitivities of the leadership? And I think continuing education and the board asking for that is the way around that issue. And then in my opinion, if you have leadership or a CEO that opposes that, I think your hospital has bigger problems than you may be aware of, because there are studies that show that the higher performing governance of a hospital is directly related to positive patient outcomes and a higher performance on a number of levels. So leadership of a hospital CEO and the other leaders in the hospital should do everything they can to promote continuing education. So that's, and if it isn't happening, I think the board needs to step up and ask for that. Couple of issues from my perspective, and one is that as we now have more and more systems giving us data, sometimes we've got so much data that it isn't information, and by the time it gets to the board, they aren't sure what they should act on unless there really is dialogue with the leadership. And the other piece is that in terms of trustees' role is that it is part of their job to ask questions. And this is awkward. I've seen examples over almost 30 years of being a trustee where people that I know from the community and that I've sit with in other committees and other environments, they walk into a hospital boardroom and they become silent. They have some version of white coat disease that doctors and nurses often laugh about, which is the issue of just the sight of the white coat sends people's blood pressure up. Well, in the same sense, sometimes in the boardroom, the white coat syndrome is that they feel inadequate, and they would ask 10 penetrating questions if they were in their own domain, in law or education or legal world, but they get into a boardroom and they are afraid to challenge the logic of what they're hearing or to say, I need to know more information. And so anything that the hospital leaders can do to open dialogue with the trustees so the trustees feel that they are in a space where they are free to ask questions and to have follow-up questions is extremely important for implementing safety and quality. I think also when the hospital leaders, the quality and safety people speak, all the suggestions that we've heard up to this point in this seminar are good ones, but I think the leaders should direct their attention to the board members, not to the slides that they're showing. And I often see that it's like a disconnect. They're running the slides and running the numbers, and they don't look at the trustees, and they don't give them the physical cues that they are open to questions and that they're comfortable with that. And sometimes the quality and safety leaders need to ask one or two times more, does anyone have questions? Did you understand that? How can I help make this more clear? And I think after a while that loosens the tensions, and it also promotes a much more effective and open dialogue about these very sensitive and very complex issues. But that atmosphere has to be in that boardroom, and the chairman of the board, that's their responsibility, and the chair of the patient safety committee, it's their responsibility, but even among the trustees and the leaders in the hospital.
Those are great tips, and I think that Bill addressed the issue of patient stories to really help engage the head and the heart. Tom Knight, your perspective as a leader in quality and safety, having years of dealing with boards and really bringing some great organizations to new levels of quality. Your perspective and your view and advice now from the other direction. Tom?
Okay, thanks, Chuck. I think a number of great points have already been brought forward. And first of all, the diversity of boards, for instance, on my own board here, I have the former CEO of Continental Airlines, and I have the Bishop of the Methodist Church here locally. So the diversity and trying to fit presentations to that diverse an audience and really clearly communicate is always a challenge. And it quite honestly can be an intimidating experience, especially when you have to give bad news. and especially to non-clinicians. It really is, it can be, you can end up really being distracted and as we say, chasing windmills in quality sometimes by, if you get too far off the base and all. So I found, in our personal experience here that it's really important to be very clear with talking with boards, to give them a chance to respond and have their questions answered. I absolutely agree that interaction and dialogue are very important rather than just pure PowerPoint presentations. The other thing you really have to do is drive out fear. That was already mentioned as well. It is a very scary experience sometimes to kind of go out of your comfort zone and to ask questions around this, but there's no stupid questions. And then, the other thing I think that is incredibly important is don't, again, in the spirit of driving out fear, it's very easy to define problems. We all can walk right now through the halls of our hospitals and define some serious problems. The question is, can you bring some solutions and a framework for in addition to just define the problem? So I think you should never leave your boards with just the terror of things that are happening and the problems and ask them to provide the solutions. You need to bring at least the framework of solutions when you talk with them as well.
Fantastic, Tom. I'm going to move to our next issue of prioritizing quality, how to get quality and safety front and center. Some of our organizations count how many minutes they cover quality and safety. My good friend Greg Meyer, who co-chairs the Safe Practices for Better Healthcare at the NQF at Mass General, they count the minutes of how many minutes that they focus on quality. There are other topics. I want to address 4 of them and then swing over to Dan Ford on the first one. But the first is root cause analysis. What about actually really getting into the meat of some of these accidents that occur? The second topic is the non-clinical quality committee chairman. I'd like to go back to Sharon and ask Sharon, what does it take? You are a chairman of a quality committee, and I know you feel comfortable doing it, and you've shared with us why and what processes made that occur. The third one is patients on boards. We're launching a leadership certification program that will be an on-ramp for doctors, nurses, and patients to become prepared to serve as very competent board members, and want to address this issue of patients on boards and perhaps go back to Rosemary on that one. And then the final one is many of our CEOs do not see this no outcome, no income tsunami coming. They're so task saturated and overwhelmed right now, they really don't realize that this wave of transparency, kind of like how Bill Scharf was blindsided by the call from the New York Times, the transparency is really accelerating. At the same time, budget cuts are going to hit us after the election, and Medicare is the most vulnerable item in the budget, the federal budget, to get hit. We know the private insurers will follow. So first question, Dan Ford, this issue of root cause analysis, I know you have passion for this.
I do. Thank you, Chuck. And I'd be the first one to say I'm not an in-house clinical expert. I have become passionate about this subject. This goes back to our own family tragedy back in the early 90s. Rightly or wrong, or fortunately, unfortunately, I've been involved in this for a number of years. And I asked if I could see the patient, see my wife's medical record. Oh, absolutely, $95, and it's yours. I said, can I get committee minutes? Somebody must have debriefed. We didn't have RCAs back then as such. Oh, no, that is confidential. And that wore on me all of these years. And as I've over the years, I've given over 60 patient safety presentations to provider audiences. I've served on, probably 10 or 11 national and local patient safety quality committees, boards, et cetera. And it is a hot potato subject. Whenever I've introduced this, the first time I brought it up, there's silence in the room. It's kind of like, we invited this guy to serve on this committee. He's making us feel uncomfortable. I think it can be very constructive. Not all patients are or family members are going to want to participate, nor should all participate. We got to deal with what I call classical CYA attitudes. At the heart of this is the fact that it's offensive to be left out of the discussions about what really happened. It's our bodies, It's our family members' bodies, and something terrible happened, and it was beyond our control, and we put our trust in the system. I think it will help to lower or remove the wall that often appears after a sentinel event. I really think it can reduce costs. There are some samples across the country of organizations in which disclosure happens right up front, transparency, apologies, and getting patients and families involved in root cause analysis, and it's a good business case. The reticence, we got legal considerations, we have tradition, we have change, peer review, role behaviors, egos. I think telling the truth is the right thing to do, and involving the patients right there at the table without contrived or pre-prepared statements, I think will eliminate, won't eliminate, but will minimize concern. I think it will help to build the trust. I know there's always the tension between the fear of litigation and transparency and telling the truth. I also think it can help with the healing process.
And Dan, we know that organizations that have invited patients into the analysis have built trust and actually not that the intention should be to reduce the financial risk, but we really know of no case in the country where they have done that and it's backfired, and we know many of them, all anecdotal, and anecdotes do not make data, but that they really have been positive. I'm going to shift to Sharon, and Sharon, you are a non-clinical business leader, and yet you feel comfortable serving as a quality committee chairman, and a lot of it has to do with the onboarding, mentoring, and other processes that were undertaken. Do you want to address those quickly? Because many people don't believe that a non-clinical person could be a really good chair, and it's clear you are.
Yeah, I would love to be able to sound in on this issue, in particular because exactly as you said, I think there have been in the past, there's thought process that you needed to be a clinical person to chair such a committee. And for me, I got to admit I was hesitant to take it on, but the process has evolved for me over the last year because of two primary reasons. One, cross-functional development, in terms of really engaging myself to want to learn and understanding the issues, and to the gentleman's last point, speak up when you don't understand, ask the question. But I think the overarching reason why my comfort level has excelled is because of the mentoring. I agreed to take on this role if I could partner with someone and seek out a mentor, and so the Chief Medical Officer is my mentor, and we purposefully talk on a regular basis. If I'm going down to the hospital for a meeting, I'll go in early and meet with him for an hour, hour and a half beforehand to talk about issues related to quality and other issues and questions I may have. So he becomes a great sounding board for me. The other opportunity for me has been to participate in internal and external learning opportunities. So not only industry conferences and webinars such as this, but then also internal training. I was there with the caregivers when we introduced the Just Culture training. I sat in on an overview with the leadership team on team steps. When I say leadership, I mean leadership at the clinical level. And that sent a very clear message to them, one, that this was important, and two, that we were willing to learn and didn't have all the answers just because we have a business background, and we were willing to partner with them. And so developing that development plan, both internally and externally, and having that mentoring relationship, not only helped me with the comfort level, but it sent a strong message to the caregiver community within the hospital system that the board members are active, they're engaged, and they care. And I'll give you a perfect example. It was just yesterday evening we had our executive committee meeting, which we meet monthly from 5:30 to 7:30. After that meeting, myself and another board member, we did rounds for 2 hours with the CEO. And I have to tell you, those evening caregivers were thrilled to see board members. And when the CEO introduced us to the caregivers and explained that we were his boss and that they should feel free to share with us any comments, any concerns, any questions that they had, you could just see on their face how good they felt about the opportunity to talk with us, even though it was just brief. But again, it creates a level of transparency and a level of caring from both our side and their side that they feel valued within the organization.
Fantastic. I'd like to go to this.
Chuck, it's Ellen, and I would like to just make one brief comment to support what Sharon was saying. Just from the it's a small thing, but I think it's really important because I saw an evolution in our hospital. We had very active, involved chairman of the Quality and Safety Committee who did many of the things that Sharon is describing. But then when that person would bring the report back to the board, to the broader board, the board itself was not prepared at the same level of being engaged and active, and there were structural issues about where the report from that chairman fit on the agenda, and we switched all agendas throughout the entire Cleveland Clinic so that all of the agenda for the broader board meetings start with quality and safety, and that chairman is told that his or her work is reinforced by the importance of it by being first on the agenda and having plenty of time to talk and having an opportunities for the other board members to ask questions of the chair of the committee. And I think that is an important point because you can easily undermine an activist chairman of a quality and safety committee if you don't have the rest of the board's work structured properly to receive that input from that board.
Great point, Ellen. And I think as we go through our board certification and leadership training, that is really one of the kind of job one is to show how the core values be reflected in the behaviors. I want to pace us. We've got 2 more slides of questions before we open up for a Q&A, and I'd like to go to Rosemary regarding patients on boards. We're creating an on-ramp not only for patients, and just before we close the webinar, Frank Giotto will address a kind of a match.com we've created to get patients and families that want to be engaged with hospitals in speaking, but also, more seriously, is getting patient representation on boards of directors of hospitals, trustees that may not be business leaders. Rosemary, we really believe that we can prepare patient and family advocates to be really competent board members by providing them the training, mentoring, and onboarding that's necessary. Do you want to comment on this phenomenon, which we believe that we can help drive and that will be positive? Rosemary?
Yes, Chuck. I think it's terrific what you're doing. I think part of it is who's the right person to be on the board who's a patient or family member. And I think one mantra I would use is that the right person is a prepared person, someone who has an appreciation for the complex system of healthcare, who's also had an experience. I'm thinking of a woman that a hospital engaged in its quality and safety work who is an engineer by background and profession, and there was an adverse event involving one of her parents. And she brought both experiences to bear in her role. So I think having a prepared person who can represent and be the patient and family on the board is a right thing to do. I would also suggest, I'm very conscious of the fear factor. A lot of what drives safety underground is that fear. And so I would hope as part of the training, not just for patients and families as they get on the board, but also everyone, is the theory of just culture and what are the rules of the road, and distinguishing between events that happen that are part of a system and those events that occur because an individual was not doing what he or she was supposed to do. Providing that framework as part of training for board members, whether they're patients or families or professionals,
absolutely terrific.
is really valuable. And again, to take that fear out of those conversations in the boardroom. I've gone into board meetings, and at first you're afraid, and I like what the person said about relationships. And I think it's also important for when you bring patients and families onto boards that you cultivate the relationships so they feel as if they're an equal partner, not, shall we say, terrified at the prospect.
Perfect. I understand Dr. Parda is back with us, so I'm going to go to the last bullet on this slide. We still have 2 more sets of questions, but what I'd like to do is, Bill Sharp, can you react to we have a crisis of waste and harm, and many of our CEOs are so mired in what they've already got as planning and have not really been prioritizing the what-if scenarios, as Jim Collins, who wrote Great by Choice recently, talks about, that the winners in a turbulent time are going to have productive paranoia, be fanatically disciplined about the basics, and then use empiric creativity, and all of them will be animated by what he calls level 5 ambition that is greater than themselves. And we see so many of our C-suite teams pretty mired down in what they're doing day to day, and just don't even see this this changing phenomenon with transparency and also tying payment to value. So Bill, on this one, and then we'll go to, I'm going to advance the slide after Bill to the next one where we'll go to Dr. Parda. So Bill, your thoughts on engaging our CEOs in the reality of this phenomenon?
Yeah, I think that your comments about Jim Collins' new book are very very apt in terms of what we try to do in terms of the productive paranoia that he describes. And so one of the things that I see as the role that I and the folks in our division have, and that is to take the complex problems and make them simple in terms of so that they can understand and connect the dots more closely. Because I think that one of the things that happens is that there's so much that the CEOs have on their plates, but they don't really see clearly in terms of the magnitude of the severity of the problem. And so it's really an issue of trying to articulate how important these issues are, and then stand in their shoes as well. See what it is that they see, and then try to articulate a position as to where safety and quality fall with respect to all the other tasks that they have.
Thanks very much, Bill. And I think communication, critically important. I think the power of stories that we mentioned earlier was also critical. Now, as we move to the issue of recruitment, onboarding, mentoring, and recurrent training and competencies, Dr. Parda, I know that you are a physician. You practiced as the chairman of a major department that has a major P&L, and then you became a board member, which provided a new perspective. We'll go to Dr. Parda on this issue of recruitment, onboarding, mentoring, and just how critical it is to get informed board members, and then back to Sharon before we then move to the types of board members, and then our final piece will be on how to leverage the testing that Rosemary so beautifully kind of got us started talking about with Bill. So, Dr. Parda, your perspective as a physician board member, who formerly a chairman of a department, and then you became a board member, and these dual views.
So I am one of 4 physicians on our board, and we have 18 board members currently, and this is a 6-hospital system throughout the Pittsburgh region. And formerly there were 30 to 40 board members, and then there were boards of all the individual hospitals, and this recently coalesced. The other 14 board members have experience mostly in the finance related fields, and we've had very limited experience from the board members in operational fields or people leadership, and very limited healthcare experience. I also think it's somewhat limiting to only have physicians with clinical and operational perspectives. So it has been very difficult to move our board beyond very focused financial assessments, and there's been a lot of financial strain in this health system as well. And I agree with all of those comments about how overwhelming this work can be, and it does require a lot of interaction and sensitivity. One of the difficulties that we as physicians have, I'm an internist first, a radiation oncologist second, is that we've been taught to solve problems like we have in tumor boards and M&M conferences, and just hitting it head on and going after it. And I have found that doesn't work very well in the boardroom. it really does take less aggressive and less of the traditional types of medical approaches that we use as we're taking care of patients. We have that approach just because we know that the intensity of the circumstances is high, and we're used to having 15 doctors in a room and disagreeing and throwing it around and not really offending each other very easily. But when it comes to non-clinical people, I really thought that comment about people being prepared and having a lot of personal experience, but also that you do have to have an open ability to speak freely. I'm the chair of the NCI Central IRB, where we oversee all of the Phase 3 cancer clinical trials throughout the United States, and it has been a huge improvement in this initiative now that we have had patient advocates on this board for over 5 years now. And initially there was a lot of angst between very high-functioning experts in the field interacting with patient advocates and the important issues that they brought to the table. And I can say that several years later that angst has really abated, and there's a lot greater ease of interaction back and forth. And I think a lot of doctors are starting to understand that it's going to take a lot more than just analytic intelligence, and you're going to have to bring a lot more emotional, social, and creative intelligence to solve these complex problems.
And as we move, I've advanced the slides to slide 66 for clinically trained board members, and I just like you to answer a quick question regarding. You also are the chairman of the Culture Committee for a transformation of your organization, of tying behaviors to culture, and you and I have had the conversations of how enlightening it's been to clinical people and tactical people that are really kind of fix the problem using science, and now understanding that there really is a science of behavior and core values and behaviors. And so quick answer there so we can keep on time, and then back to Ellen B. regarding nurses on the board. And I'd like to kind of wrap up this piece of how critically valuable it is to have clinically trained people, but that they have to learn new things. And so, Dave, your comments and experience regarding being the chairman of the Culture Committee, which is about as far removed from you and I and our roots in radiation oncology as we'd think.
Yeah, Chuck, I tell you, as I interacted with a lot of my clinical and operational colleagues throughout the health system, they really did look at this as soft, abstract, philosophical drivel, and I have really had to stand firmly to really explaining that this is absolutely the opposite. It's all about discipline, and someone else spoke about that, and it really is about the discipline to assess patient care and colleague care and quality and safety and those issues primarily, and to have open interchange between all levels of people throughout the clinical and operational environments, including non-clinical people. So it really is about the discipline to open it up to much more transparent problem-solving interactions.
Fantastic, David, and I'd like to remind everybody in the right lower quadrant of your screen, we are polling you regarding, would you like to have more webinars regarding communication of proposals to the boardroom? If you're a quality leader, if you're a leader in any aspect of your healthcare system, hospital, inpatient, outpatient, whatever, would you like more there? Would you like more continuing education programs on value-based purchasing? We're really going to dig into that issue of how payment's going to get tied to quality. Also, programs specifically for trustees, because we have a program that we'll be launching here in the next 2 months that will be very comprehensive for onboarding of multiple categories of trustees and quality leaders of the committee, the quality committee, the board, and then also the value of quality improvement programs. So I'd like to shift over to Ellen B. You're a nurse. You're on a board. Nurses are so genetically predisposed to serve and take orders. It's been a very hostile and tough environment for nurses over the last couple of years. We've lost a terrific number of CNOs, and so we're going to try to uniquely address their specific challenges. But you want to just comment on the great value that we believe that we can have by getting nurses on the board as really competent trustees?
Yes, and it does, I agree, it would contribute greatly to having a culture change in the boardroom, because when a nurse is in the boardroom, different questions get asked, different eyes look at the same information, listen to the reports differently.
Ellen, you're pretty garbled right now. If you're on a speakerphone, we can't hear you very well.
Okay, I apologize. I was saying that that nurses can make a very direct contribution to changing the culture in the boardroom itself. The presence of a nurse in a boardroom, and by this I need to make clear to our audience, I do not mean that the chief nursing officer sits on the board. I am talking about a person whose expertise is in nursing and care delivery, that is an independent person that comes on the board, recruited to the board like other leaders with backgrounds in other disciplines and other businesses. So that's when I'm talking about a nurse trustee, that's what I'm speaking about. And having a person like that in the board does change the conversation. I believe it role models interprofessional analysis of hospital operations and issues and policy decisions. Nurses, once again, were number one for 11 straight years as the profession most trusted by the American public for honesty and ethics. And I think that's a wonderful message to give out to the community and to patients and families that this most trusted person has a leadership role on the board of the hospital. The other thing I'd like the audience and my panelists also to know is that only 6% of not-for-profit hospitals have a nurse trustee. So we have a lot to do to change this, and I think nurses are the hospital's greatest budget expense, and they're also their greatest asset. And it's real important, I think, to have a nurse and other people with clinical backgrounds on the board.
Ellen, absolutely, and that's why we'll have a specific track for the development of nurse trustees who would like to become a trustee and those that would like to bring them along. We've let Tom, we've not had Tom in this discussion because we've wanted to rotate around to all of our speakers. Our final slide for Q&A on to our panel is now bringing it back to Rosemary's initiation and my focus on a specific tactical example. So the example that Rosemary brought up at the very beginning is this issue of overuse. And if we really look at testing and we look at the issue of overuse, underuse, and misuse of testing, and we then drill down in our example of CT, it becomes very, very clear that we do have a significant challenge. The studies in the radiologic community, and we're collaborating with and working very closely with the World Health Organization, the American College of Radiology, the American Association of Physicists, the Image Gently group that helped pioneer a reduction in dose for kids with protocols that Greg Meyer and I prosecuted through the NQF Safe Practice to become a safe practice. All of this information is really reflecting that we've got a significant overuse area. Now, we have had the benefit of now looking at data of 20,000 orders of imaging a day from 35 million covered lives through one of our wonderful organizations that's involved in purchasing. And the shocker was that what they describe a sentinel effect, which is like the black and white cop car that's in the median as you're driving at 80 along Highway 5 here in California, and you see that car and you slow down, you see the police car. Just the knowledge physicians having the knowledge that they are being monitored regarding the imaging that they're ordered will generate a drop in an unmonitored group across the country from 20 to 30%, which is a huge wake-up call. Those aren't denials. Those are just recognition. So do we have a challenge? Yes, we do. Do we have a radiation issue? Yes, we do. Now, we're working with the leaders in this field on both ends of the continuum that say all radiation is very, very dangerous, and those that say we're really overestimating the danger. Experts that have no conflict of interest and no relationship with industry, experts on both sides of the table, are having honest arguments as to what dose really will cause adverse events, but they're all in agreement that we can't deny life-saving potential tests, but they're all also in agreement that we need not to do unnecessary tests. The overuse generates what we call incidental omas, which are then nodules in the chest or in the adrenal glands or in the liver that then require a whole vast group of more testing. So what I'd like to do is come back now as we're in our last 10 minutes of our webinar, and I really appreciate our speakers' comments and the pace that we followed. Rosemary, as we go back to this issue, I'd like to ask our panel, starting with Tom, how do we start engaging the C-suite? Tom Knight, you've had great experience at, now you'll be, at multiple great organizations. How do we engage the C-suite on this this issue? Secondly, Sharon and Ellen and Dave Parda, what do boards need to know and want to know, both non-clinical and clinical? And then as we look at this as safety officers, many of our audience today are not radiologists. They're not radiation oncologists like you and I are, Dave. They're not laboratorians, and they don't understand that the laboratory issue is almost identical with overuse. It's about 20% to 30%. But they're not experts in this field. And then finally, I come back to Dave, or I come back to Bill regarding the powerful use of stories. So let's start off with Tom and just, how do we start to weigh in, knowing that the data is just going to be so ample that's going to show definitely we have an overuse issue. It's tied to volume that we know generates revenue. As we move to a value-driven environment, the dialogue won't be, hey, how many CT scans did you get that paid money? It's how few did you use properly because you're running an ACO. So the whole paradigm is going to shift. So Tom, how do we engage the C-suite in this area?
Well, Chuck, I think I first step back and kind of look at the clinician that ordered the scan. It was very interesting to me. It sounded like all 9 of these CTs occurred in the ER, if I'm correct. And the other thing that was very interesting, I thought was that the diagnosis that was made was actually an ambulatory diagnosis. So, there are a lot of pressures right now in the emergency room. Some of it's malpractice, some of it's time pressure. That's accelerated, obviously, by the new CMS measures looking at throughput in emergency rooms. So, there's a lot of things going on here. The other thing you mentioned, I think, is hugely important. I would estimate that the risk of a false positive result in terms of harm to the patient ultimately because of a workup that was unnecessary was at least 5 times. So that's the iceberg here, is not only are you exposing patients to radiation, but you're exposing them to false positive results, to further invasive testing that potentially does carry significant risk of harm. I think that's the big iceberg and the unquantifiable risk as well here. So as I look at this, I said, what would have prevented?
Simplify our message? Do you think we have to? Any tips on the message? We have a lot of quality and safety leaders on this call.
So I would say the message you have to bring to the board is expose them to the problem, but also how do we begin to address this? And so what really that doctor needed, access to the prior images that were there if he didn't have them, the ability to speak with a radiologist to say what's the right test for this, and the assurance that this patient, once they left the ER, would have some kind of follow-up. To me, are the 3 big issues, and that's what you have to start exposing the C-suite to, is how do we systematically begin to develop these solutions, put revenue and resources to develop these solutions that are not revenue generators that are so important.
One of the things that we're going to do in the movie is the first thing the board needs to do is practice forgiveness, and that is the forgiveness of an administrative team that didn't know the tsunami was coming, and that money will have to be spent in the spirit of the escape buyer that Don Berwick really got us to be aware of, that at a time when you reflexively want to cut a budget, you may need to invest in those kinds of things to really quell overuse and really provide an escape from the way that we do it today. Is that Rosemary? Yes, go ahead, Rosemary.
Chuck, just very briefly, how to have this conversation, how to begin it. One, I think we all have to assume that we're all learning how to do this, and particularly on this topic of CT scan use. I would start with what I call the training wheel issues. Before we can ride a bike and really do it well, we've got to figure out how to do it. What are those areas where there's consensus? You know, the double chest CT scan measure, that's one where there's pretty much a consensus that we should not be doing two of these, one with contrast and one without, in close proximity to each other. We should do one and not the other. So it's not as if there's too much clinical difference of opinion here. So that's one place where I would start, where there's consensus. Here's another one that would really be understandable to a lay board. I've worked in the palliative care field for a long time, and we have these young residents coming in to do palliative care fellowship trainings, and they want to do CT scans on hospice patients. So how do we retrain people to say, well, how are you going to use those findings, and how will it be different in the care of that patient? So let's go to that high-hanging fruit where even lay people would understand that some of these things we can take out of the system and thereby add value to the patient and make them safer.
Yep, the chains of habit are too light to be felt until they're too heavy to break. One of our business gurus has taught us that, and there's some of them are just habits. Sharon, what do now that you know that there is an issue, as a non-clinical board member who's the quality committee chair, what do you want to know?
I want to know two things primarily. What do we need to do to avoid this from happening again? And what have we done to support the caregivers that were involved? That would be my two starting questions.
And this is Ellen, and I'd like to say that the questions that would come from me if I heard this were two things. Can our electronic health record system provide any assistance in terms of flagging issues or flagging number of times people have had these scans within certain parameters that we could set using our electronic health record system? That would be one question, because we're investing a lot of money in these, and it would be great if this was something that could help with this. And the other would be my role would be to have a heightened sense of urgency.
I think we've lost Ellen. We can't hear her. Bill, would you finish this up for us on, you are a general surgeon. You had to wade into radiology. The final two bullets are the non-radiology quality leader and use of stories. And then I'd like to go to Frank Giotto, who will describe our speaker link program that is helping hospitals connect with patient and family champions, before we go to Dan for the last word. So, Bill, would you please just react? You're a general surgeon. This area of imaging, you have some lessons learned in the board. What's your advice to our quality leaders?
Well, the first for us is that we had a story to tell, and it was our story. It was our story about the light of transparency. It was our story about the potential of radiation exposure. And there's another story, too, that I should mention as well, is that when I was doing this presentation, we showed comparative data from all of our facilities. So we had this range or extent of variability. And during the presentation, one of the CEOs raised his hand, and he said, Bill, can you tell me what our results are? And I turned over, stepped away so that he could see and show that from the facility where he was, is that they had a 0 rate of double CT scans of both the chest and the abdomen. And at that point in time, he said, yeah, I just want to make sure that everybody knew that we had a 0 rate of double CT scans. And that provoked a moment of laughter, and it also sent down the gauntlet. It wasn't me telling the C-suite what to do. It was themselves setting a level of competition in terms of where to go. And it was after that that I heard a number of informal stories from radiology directors who said, you know, we never used to see our CEOs very much, but more recently we've seen them. So we're just kind of curious, what exactly did happen? And I was able to share the story with them too.
Bill, thank you. I just want to thank our panelists. I want to hand the baton over to Frank Guilleteau, who's going to just spend a couple minutes describing the progress with the program that we established as a result of asking the patient advocacy community, what do you need that you don't have to connect with hospitals so that you can be able to speak with them and that they can find you and you can find them. Frank, would you take it away for a couple of minutes, and then we'll go to Dan Ford. And then I'd like to have the speakers stay on after we shut down the webinar so we can do a rapid performance improvement loop to see what we can do better next time. And we thank everyone for your contributions, but please stay on. Frank, take it away.
Sure. Thank you, Chuck, for giving me the opportunity to promote this initiative that we've had underway. It is an exciting time, and obviously organizations, as we heard today, are increasingly asked to have patient advocacy brought into their environment, including the boardroom. And what we have realized, and hearing from these same organizations as well as the patient advocates, there is an inherent challenge in identifying who these individuals might be, and then more importantly, making sure that the topics that they bring into the boardroom are appropriate. With that, that insight kind of led us to developing what we refer to as SpeakerLink. And internally, it's kind of been called the match.com. So we identify really two user sets for this environment, and one would be speakers that are trying to present themselves as advocates that can share their experiences both locally with their local healthcare organizations, but also nationally. And then hospitals or other care organizations that are looking to engage these patient advocates and having them share their stories to inspire the board, but also to give organizations directions. So as you go to this website, which is SpeakerLink, you'll see that you have the option to identify a speaker or to become a speaker, and we provide a simple search tool function that allows you to enter the information that you're seeking either by keywords, by location, or even as you drill down, after you've clicked down into the search function, look at such things as the range of fees that they cover, and then this information is presented graphically on a map. When you drill down, actually, we have one of our speakers here. Dan Ford is one of our speakers on SpeakerLink. So if you were to drill down on Dan's profile, you'd see that he provides his biography, his background, some of the topics that he's willing to engage organizations with. He mentioned that he had given over 60 different presentations on the topic, so you can feel comfortable when you're engaging him that he is a person that is qualified to talk to your board. So our goal in this effort, and so far we've been able to have a pretty good response. We've got over 100 patient advocates that are sprinkled around the country. With that, we've got about another 50 that are currently filling out their profiles. And what we are trying to do is raise the awareness and have any folks that's on this webinar that is interested in becoming a speaker and provide their information so that they can be engaged locally or nationally. Feel free to do so. There's no initial cost to do that, and we feel that it's a great opportunity to meet, I think, a rising need, and also have you share some of your experience that will help both your local organization and national organizations. So
thank you, Frank. I'm just backing the slides up. SpeakerLink, and we will be soon be offering a course that will help train speakers and seekers to know how to engage and be able to have optimize those relationships as we go forward. We're just a few minutes over. I'd like to thank our fabulous panel. I'd like to have them stay on so we can do a rapid performance improvement cycle, but most importantly, I'd like to come back to Dan Ford, one of our nation's real treasures as a patient advocate and tireless champion. Every other week, Dan is on at 7 in the morning with me out here in California with a number of patient advocates who just donate their time to figure out how to get these messages to hospitals. And Dan, it's an honor to have you close us.
Thanks, Chuck. You are a national treasure as well, and I want to thank you for orchestrating all of these webinars. Last 2 summers, I've had the opportunity to participate in a patient safety conference on disclosure in Telluride, Colorado. Rosemary was at the last one, and we had the honor also of having Lucian Leap with us this last one. And Lucian feels that how we treat each other impacts patient safety, and that the lack of respect is the source of most problems in hospitals. You know, we can deal with the clinical issues, we've got a ways to go. The human piece really takes a lot of work, and I have felt that ever since our family's tragedy and my own efforts, and that's why I've gotten involved. One other quick thought, I work with a lot of boards on board searches, board director searches, CEO searches, board involvement with boards, and some C-suite searches. And I have long felt that a good board can be that hidden jewel that can cause constructive change faster than the sluggish pace of change that we're still on now as regards safety and quality. Too often we say, okay, we're going to talk about finances over here, we're going to talk about safety and quality over here, and we separate those subject matters and the others, and they're so closely related together. This has got to be in concert with a good CEO. It's got to be supportive of a good CEO. It's got to be in concert with clinicians, with housekeeping, with virtually the frontline nursing staff, with virtually everybody in the organization. A lot of points to this, a lot of really important points, and these are really good, but I will end there, and thank you for inviting me, Chuck.
So Godspeed to everyone as you go about your day, and thank you, Dan, and thank you, wonderful panel, and we'll wrap up. Our next webinar next month will be really taking a deeper dive in the training and preparation of our trustees as well as our C-suite, and we'll be continuing to just relentlessly focus on the team play of the team sport in the boardroom. So thank you so much, and that ends our webinar today. 2 business days, we'll have a transcript, and you'll be able to watch it and listen to this presentation asynchronously. Thank you and have a wonderful day.